Okay, this is the lecture for Chapter 50, drugs that are affecting the pituitary, thyroid, parathyroid, and hypothalamic function. Just as a review, remember that your anterior pituitary is going to secrete ACTH, GH, and TSH, whereas your posterior pituitary is going to secrete ADH and oxytocin. So here's our concept map for the different drugs that we're going to be using or going to be covering in this lecture. So again, this is going over that the physiology component there on the anterior lobe of the pituitary controls the function of the glucocorticoid hormone levels, ACTH, body growth and metabolism, which is GH, which is your growth hormone, function of the thyroid gland with secretion of the TSH, gonadal function, which is going to be FSH and LH, which is follicle stimulating hormone and luteinizing hormone, and milk production and breast growth with secretion of prolactin. Then your posterior lobe of the pituitary gland stores and secretes two effector hormones, which are hormones that produce an effect when stimulated. That would be oxytocin and vasopressin, which is also known as antidiuretic hormone. Then you've got your thyroid gland function, which controls your cellular metabolism and promotes normal growth and development. And then you've got your parathyroid gland function. Your parathyroid hormone affects three target organs, which are the bone, kidneys, and the GI tract. The major controlling factor for parathyroid hormone secretion is serum calcium. One thing I'll say about your parathyroid glands, you do have 4 parathyroid glands that you note right there, located really just right anterior to the thyroid glands, and those parathyroid glands are independent of your thyroid gland. Yes, they are all in the endocrine system, but your parathyroid has nothing to do with your thyroid gland function. Now, a lot of times if there is, a nodule or an enlargement or growth or something, a lot of times it will be embedded into the thyroid gland tissue because of the closeness and proximity there. But it does not mean that 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 one has anything to do with the other. The main thing that we do is we check on the lab work if the serum calcium is elevated. Then I'm going to always follow up by checking a parathyroid hormone level because that is a direct correlation because very seldom is there ever a reason that calcium is going to be elevated unless the parathyroid gland has caused a problem. I will direct you to this particular figure in your book. It's located on page 1071. It's figure 50.1 that goes over that whole physiology and what's going on there in the body and the hormones that are released at that time, and which target organ it stimulates. And so I will also encourage you to look in your book if you need a refresher on the endocrine gland function. I'll encourage you to look at those pages in your book. All right, then looking at the pathophysiology, you've got your anterior pituitary gland dysfunction. That's going to include growth hormone deficiency and growth hormone excess. Growth hormone deficiency is covered in your textbook, as well as growth hormone excess. Growth hormone excess, we're looking at gigantism and acromegaly. And it covers both of those going into those particular disease processes. Your posterior pituitary gland dysfunction, your major disorders are diabetes insipidus and syndrome of inappropriate antidiuretic hormone. Thyroid gland dysfunction, hyperfunctioning or hypofunctioning gland, and malfunctions that may be caused by either a congenital defect or by a problem that occurs later in life. Note that I have put there to know your signs and symptoms of hyper and hypothyroidism, and we'll cover those in just a little while. All right, Parathyroid gland dysfunction. Hormone is a major regulator of serum calcium and phosphate. A decrease in serum calcium concentration is the dominant regulator of parathyroid hormone with a response rate of just a few seconds. A decrease in phosphate causes an indirect effect on parathyroid hormone by combining with calcium and decreasing serum calcium concentrations. Now keep in mind I said that if my patient had an elevated calcium level, I check their parathyroid hormone, but you have to understand that these glands work in a negative feedback mechanism. And so as the calcium level is rising, the parathyroid hormone is trying to stimulate more of that calcium release. I did say that the parathyroid glands are located anterior to the thyroid glands. That would be posterior to the thyroid glands, and you can tell that by that picture there. All right, in growth hormones, growth hormone deficiency, which leads to short stature, was initially treated with growth hormone injections extracted from the pituitary glands of cadavers. However, presently, synthetic human growth hormone is produced from recombinant DNA, and that is what is available. Growth hormone therapy is very expensive, and insurance does not like to pay for it. So, therefore, we're going to have to really make sure to prove that they have a growth hormone deficiency to be able to prescribe this drug. And the prototype drug for this is somatropin. Pharmacotherapeutics. It is used as a long-term replacement of inadequate endogenous growth hormone secretion. Pharmacokinetics. It is administered sub-Q and IM. It's excreted in the liver and the kidneys. It stimulates cell growth and cellular mitosis and facilitates cellular uptake of amino acids for protein synthesis and promotes use of fatty acids for energy. Contraindications and precautions. Growth promotion in children with closed epiphyses. Closed epiphyses, epiphyses are going to be your growth plates. So if we do x-rays of these children and their growth plates are already closed, that's going to be a contraindication for us giving it, because the purpose of this is to grow them and to give them a better stature or a higher stature, however you want to think of that. And if their growth plates are already closed, they have no more potential for growth. So that's the reason why we have to we will do the x-rays and all, and if they have closed epiphyseal plates, then we will not administer this drug. So it's going to have to be in a certain developmental age range that we're going to be using this particular drug. Adverse effects: headache, hypertension, joint and back pain, peripheral edema, muscle aches, and rhinitis. Because of the fact that we're going to be encouraging them to grow, you're going to get a lot of those growth pains or growing pains. That's why you're going to see the joint and back pain and those kind of things. Drug interactions, anabolic steroids, androgens, estrogens, or thyroid hormones may accelerate epiphyseal maturation. Those particular interactions are listed on page 1080, table 50.6 in your book. I'll just direct you to those, as well as the specific paragraph about it is on page 1079 in talking about your drug interactions there. On health status, we want to make sure to assess their medical history and any contraindications to the drug. It is a pregnancy category C drug. I think that you can easily see that we would not be administering this during pregnancy. We do need to assess their ability to adhere to the medical regimen, because as you can see, it's going to be a lifelong, if you note back to where we talked about the pharmacotherapeutics, it is a lifelong long-term replacement of growth hormone. So when we say long-term, they're going to be on it for quite some time. And so with that, we're going to need to make sure that the parents, the children, as well as financially, that they can adhere to the medical regimen. We do want to assess the environment where the drug will be given, because again, it's an injectable, so we want to make sure that house is clean, that they understand those concepts and all of that. On maximizing therapeutic effects, hypothyroidism may develop during somatropin therapy. So we want to make sure to keep a check on those thyroid levels. And patients who require chronic cycling peritoneal dialysis should receive their doses of somatropin in the morning after the dialysis is completed. And that's not really, which I will say that most people who have these types of deficiencies and things, it may be, that they're going to have other health problems. And so that's where you're going to see those patients who are on dialysis. But do notice that's peritoneal dialysis. We're not talking a hemodialysis. In minimizing adverse effects, growth hormone therapy may induce insulin resistance. And so we just need to be aware of that and be aware of how to accommodate for that, and to pay attention to their glucose levels and those kind of things. Be alert for the development of a limp or complaints of hip or knee pain, and tell parents to do the same. We do want to make sure that they're aware of the potential for bone development, growth, the growth and development, the acceleration of bone growth, and the problems that it could cause. All right, in patient and family education, explain that this drug is replacing an important growth hormone. We do want to explain to them the proper administration of the medication. Like I said, it's either going to be sub-Q or IM. You can note there the little figure showing you the sub-Q sites. We do want to, in the ongoing assessment in patients who are taking somatropin, we do want to evaluate thyroid function at regular intervals, because hypothyroidism compromises growth hormone drug effects, and that's because of that, of the accelerating epiphyseal maturation there. So patients taking somatropin should have which lab values monitored on a routine basis due to adverse effects of the drug therapy: TSH, CBC, glucose level, both A and C, or all of the above, and that would be A and C, because it can cause hypothyroidism and glucose intolerance. Therefore, these lab values should be monitored during therapy. All right, and talking about your posterior pituitary hormone regulators, posterior pituitary stores two hormones that are produced in the hypothalamus: vasopressin and oxytocin. Also, back up for just 1 second to somatropin, on page 1082 in your book, under the community-based concerns, it's box 50.2. It does state in here where treatment generally lasts 3 to 9 years. That's what we mean by long-term replacement therapy. And it is a lot of times covered in part by insurance. However, the cost of the treatment can be as much as $50,000 annually. And so that's a big indicator for people as to whether or not they can afford the growth hormone and all. And in your memory chip there, your major contraindications being closed epiphyses, we talked about that, and cranial lesions, mainly because of the fact that we're talking about the pituitary gland being in the brain. That's where this is, working on those particular hormones. And so anybody who has a cranial lesion, we will not want to give it to them as well. On your patient education for somatropin, proper preparation and storage of the medication, and proper sub-Q or IM injection technique, which we talked about. All right, so going into now into the desmopressin. The posterior pituitary stores two hormones that are produced in the hypothalamus: vasopressin and oxytocin. Desmopressin and vasopressin are synthetic analogs of the naturally occurring posterior pituitary hormone. Your prototype drug here is desmopressin, or DDAVP. You'll probably hear it referred to that as that in clinical setting, most likely. Pharmacotherapeutics, it manages central DI, which is diabetes insipidus, and nocturnal enuresis. Nocturnal enuresis is children who have bedwetting, or people who have bedwetting, because occasionally that can happen in adults too, or in teenagers and things. But that's wetting the bed at night, and maintains homeostasis in hemophilia A. Your pharmacokinetics, it is administered intranasally, orally, or parenterally. In the parenteral form, it's IV or sub-Q route. It's metabolized in the liver and excreted in the kidneys. The pharmacodynamics, it interacts with V1 and V2 receptors, and those are listed in your book under pharmacodynamics. It goes into talking about that a little bit more in depth, so I'll just direct you to look there in that particular paragraph. In the core drug knowledge, contraindications and precautions would be hypersensitivity. That's the only contraindication to desmopressin. There are also some cautions that are listed there in your book, and so you want to use caution with, with some of the specific routes of delivery. But the only true contraindication is hypersensitivity. Your adverse effects: abdominal pain, a transient headache, nasal congestion, nausea, rhinitis, and facial flushing. The most adverse effects of desmopressin are mediated through the V1 receptor, acting on vascular and GI smooth muscle. Adverse reactions are mild and infrequent, and are often resolved whenever the dose is reduced. The mild abdominal pain and cramping, transient headache, and those particular ones that are listed there, the nasal congestion, nausea, rhinitis, and facial flushing, those are reactions for intranasal and parenteral administration. Injection of desmopressin, if we were giving it in the IV or in the sub-Q route, that would be local erythema, burning, pain, and swelling, like an injection type site reaction. And the oral administration of tablets has shown a transient increase in the AST levels, which are the liver levels. So those are all listed in your book as well. On your drug interactions, that table, and I don't even think they list it into a table format for desmopressin, and they don't. It's just a small little blurb there on page 1085 underneath desmopressin. Carbamazepine, chlorpromazine, and non-steroidal anti-inflammatory drugs. And for the core patient variables, we do want to assess for conditions that require drug therapy, so those particular diseases, that the conditions that are going to be getting desmopressin, which is again going to be that diabetes insipidus, the hemophilia A, and the central diabetes insipidus, nocturnal enuresis, and homeostasis in hemophilia A. It is a pregnancy category B drug. We do want to assess lifestyle activities and the use of recreational drugs, and we want to assess the environment where the drug will be given. And with children, safety and efficacy of the parenteral version in children, that means children less than 12 years of age, have not been established, as well as the intranasal version in infants less than 3 months of age has not been established. Infants and children require careful fluid intake restriction to prevent possible hyponatremia, water intoxication, which can cause seizures in children. So there are some lifespan and gender things there with children that we need to be careful with. Again, I'm talking about the pregnancy category on this one. If the patient has a central diabetes insipidus and they're pregnant, it's going to have to be that the benefit is going to have to outweigh the risk for the mother and the fetus before we go administering it. So maximizing therapeutic effects, we want to establish baseline values for weight, blood pressure, electrolytes, and urine-specific gravity. We do want to protect the ADH solutions from agitation and temperature extremes. To minimize adverse effects, we want to assess the patient for pre-existing cardiovascular or renal disorders and monitor the patients carefully for cardiac reactions from desmopressin. And both of those paragraphs in your book cover that. Patient and family education. We do want to provide information about drug therapy to the patient and the family. Alcohol can alter the therapeutic response to desmopressin, and so we want to make sure that we want to caution patients against consuming alcohol during therapy, as well as that's going to include over-the-counter products that contain alcohol, namely cough syrups and those kind of things. And they need to read the drug label to make sure that they don't, that the drug does not have, or that whatever they're taking over the counter doesn't have alcohol in it. We do want to instruct patients taking desmopressin to monitor their urine-specific gravity and intake and output, as well as to weigh themselves daily to determine the drug efficacy and to find out how well that drug is being affected. Decreased urine output and thirst are signs of a therapeutic drug response with desmopressin, and if they're on it for prolonged periods of time, of course we're going to have to do EKG studies periodically, and we'll have to do periodic lab studies to make sure that they're not becoming too hypovolemic at that point. Desmopressin is used to treat, and that would be all of the above. It's used to manage central diabetes insipidus, primary nocturnal enuresis, and episodes of spontaneous or trauma-induced bleeding. Parenteral desmopressin maintains homeostasis in hemophilia A and von Willebrand disease type 1. All right, so moving right along into the thyroid drugs. Thyroid hormones influence essentially every organ system in the body. Thyroid disorders involve an alteration in the quantity of thyroid hormone secretion, enlargement of the thyroid gland or goiter, or both, and are classified as either hyperthyroidism or hypothyroidism. Hypothyroidism may be mistaken for the normal aging process. The only treatment for hypothyroidism is lifelong replacement of thyroid hormones that are adequate to meet the individual's metabolic needs. Our prototype drug here is levothyroxine. Levothyroid, Synthroid is what you've also heard it as. And here is Hattie, the hyper hottie, as I said in class. And to give you the, your signs and symptoms there of hyperthyroidism, they have an intolerance to heat, so they're always hot, so they're sweating and constantly. Fine, straight hair, bulging eyes, facial flushing, an enlarged thyroid. Oftentimes they're going to have the goiter, tachycardia, an increased systolic blood pressure, breast enlargement, weight loss, muscle wasting, localized edema, amenorrhea, diarrhea, tremors, finger clubbing. Just think about everything is speeding up. So that's a lot of where you're going to get that diarrhea from. You're going to get the tremors. A lot of times, difficulty sleeping, those kind of things. Tachycardia, everything's speeding up. So that's Hattie, the hyper hottie. And then for hypothyroidism, this is flow slow, the cold hypo. And notice that intolerance to cold, they're freezing all the time. They have a receding hairline, facial and eyelid edema, a dull blank expression, extreme fatigue, thick tongue, slow speech, anorexia, but even with the anorexia, they're going to have weight gain a lot of times. And notice that that's in the late clinical manifestations is the weight gain, but in that is where you're going to notice, they may say that they're just not really all that hungry, and they don't eat very much, but they always are gaining weight. Brittle nails and hair, menstrual disturbances, constipation, muscle aches and weakness, dry skin, lethargy, apathy, and hair loss. So everything's slowing down. So that's why he, and I think we decided we were going to call him maybe Bo Slow, but Flow Slow was what I came up with. Late clinical manifestations is subnormal temperature, bradycardia, weight gain, a decreased level of consciousness, thickened skin, and cardiac complications. In pharmacotherapeutics, it is used as a replacement therapy in hypothyroidism. And pharmacokinetics, it is administered orally. metabolized in the liver, excreted in the bile, and its onset is 6 to 8 hours. And pharmacodynamics, it acts as a replacement for the natural thyroid hormone. And then for contraindications and precautions, hypersensitivity, thyrotoxicosis, and acute MI complicated by hypothyroidism. Those are covered in your book because the metabolic stimulating effects of levothyroxine can worsen the MI, can cause arrhythmias, and can lead to further complications. And thyroid hormones may precipitate an acute adrenal crisis. So it's also contraindicated in patients with an uncorrected adrenal insufficiency. I will add to that list. There's lots of things listed there in your book. There's a whole thing listed in there about its pregnancy category and those kind of things, and patients that we need to be careful with using it in. So adverse effects: hypertension, tachycardia, arrhythmias, anxiety, headache, nervousness, GI irritation, sweating, and heat intolerance. So just think about that. If we have too much of that thyroid hormone going on, we could potentially push them into a hyperthyroid status. So that's going to be what should lend you to think of the different adverse effects. You should think, because levothyroxine is used to treat hypothyroidism, so your adverse effects of it are going to be coming from and are going to mimic those hyperthyroid symptoms. And I know that sounds confusing, but we're treating flow with that has all those current symptoms going on. But with too much of that hormone on board, we could turn him into Hattie. So that should be where you should look for your adverse effects to come from. There are many drug interactions with levothyroxine. If you'll look on page 1089 in your book, it's table 50.8. And the main thing I will say there is that with levothyroxine, it should be given on a completely empty stomach. That's what we always encourage patients to do, is take it on an empty stomach. And a lot of times I'll tell patients to take it first thing in the morning before they eat or drink anything. Some patients will wait, and instead of taking it with their supper meds, they'll turn around and take it just at bedtime. So I would also, but main thing is, and it also does not need to be taken with milk, because it will interfere with the way that the drug is absorbed, and you will see levels that are not being controlled. Also, we see with levothyroxine that if your levels are not being controlled at the current dosage, you're taking it correctly, and we see that there's still if there's still a real fluctuation in your TSH levels, a lot of times what we'll have to do is we'll have to turn around and switch them to a brand name only Synthroid to be able to actually get it better controlled, because it may be that the generic form is too it alters that TSH too much. So health status, we do want to assess for any contraindications to therapy. The lifespan and gender is a pregnancy category A drug. We're going to continue to administer levothyroxine during pregnancy, and actually an uncontrolled hypothyroidism can lead to miscarriage as well. So we definitely want to encourage patients that this is a drug that they are going to continue to take, even if they're trying to get pregnant, and especially if they're trying to get pregnant, to make sure that they are able to help that fetus to be as viable as possible, and that pregnancy to be as viable as possible. We do want to assess the ability to adapt to long-term therapy. They have to understand they're going to be taking this for life. There is no change in that, because without it, they're not going to do well. So they do need to realize that it's long-term therapy. We do want to assess the environment where the drug will be given. Maximizing therapeutic effects. Replacement therapy is a lifelong occurrence. During drug therapy, we do want to monitor cardiovascular response and serum thyroid function on a routine basis. The way we measure that serum thyroid function is going to be through TSH, and most likely a free T4 level as well. Minimizing adverse effects. Young adults without evidence of coronary artery disease can usually begin a full replacement dose of levothyroxine. Now, if we have patients who are older, who've had any type of instance of coronary artery disease, we might give them a reduced dose instead of a flat out full replacement dose. Patient and family education, we do want to explain the purpose of drug therapy to them and advise them to avoid over-the-counter drugs. The main thing there with avoiding the over-the-counter drugs is going to be, to make sure that they're not taking anything that is going to interfere with the medication that they're taking, because a lot of drugs, over-the-counter drugs, contain ingredients that interfere with your thyroid function, and so you just want to encourage them to avoid the over-the-counter drugs unless they've been directed that they can take them. Ongoing evaluation and assessment in patients taking levothyroxine. We do want to monitor serum thyroid hormone levels periodically. And I will direct you to your memory chip on levothyroxine. It's on page 1091 in your book. We do want to administer the oral drug as a single daily dose before breakfast, and like I said, with no milk and with no other medications. It does carry a black box warning that it is not for use for obesity or weight loss. There was a push for a while in weight loss clinics to prescribe levothyroxine to stimulate weight loss, because of the fact if you put somebody in a hyperthyroid status, they usually will have weight loss. However, that is definitely not the route that we want to go for weight loss. I will direct you back as well to page 1086 in your book on the memory chip on desmopressin. The only thing I will make note of there is the lifespan alert. Infants, children, and the elderly require careful fluid intake restriction to prevent possible hyponatremia and water intoxication. All right, on your antithyroid hormones, or antithyroid compounds, hyperthyroidism is treated with thyroid hormone antagonist drugs, surgery, or radioactive iodine, and that is covered in your book too. The purpose of treatment is to reduce the amount of functional thyroid tissue that's going on, and your prototype drug here is methimazole, or MMI. Pharmacotherapeutics, it is for the palliative treatment of hyperthyroidism. It is also used as an adjunct in preparation for surgery if they're going to have a thyroidectomy. Also as an adjunct to radioactive iodine therapy, or to manage a thyrotoxic crisis. If a thyroidectomy is contraindicated or not advised, MMI is the drug of choice for the treatment of hyperthyroidism. It is administered orally, metabolized in the liver, and excreted in the kidneys. It inhibits the synthesis of thyroid hormones, is how it works. Contraindications and precautions would be hypersensitivity. Anyone who has a known hypersensitivity to antithyroid drugs. It is a pregnancy category D drug, D as in dog, and is contraindicated during pregnancy and nursing because the drug does cross the placenta and is excreted in the breast milk. Adverse effects: hives, itching, rash, fever, arthralgia, joint swelling, vertigo, drowsiness, nausea and vomiting, and an altered taste sensation. Those are all covered in your book as well. Drug interactions: beta blocking agents, theophylline and warfarin. That's only covered in the paragraph in your book there, spanning page 1092 and 1093. Health status: we do want to assess for contraindications to therapy. It is a pregnancy category D drug, which we talked about just a few moments ago. We do want to assess the ability for them to adapt to long-term therapy, because again, they're going to have to be on it for a extended period of time, and so we want to make sure that they understand that. They may have to have that prolonged therapy, and it does. The drug can be taken once a day or in divided doses every 8 hours around the clock. So it may be that that we have to help them understand that divided doses thing and taking things at the correct time. We do want to assess the environment where the drug will be given. maximizing therapeutic effects, we want to ensure that the drug is being administered appropriately. We want them to be taking it the way that they're supposed to be taking it so that it can have the best effect. Minimizing adverse effects during drug therapy, we need to arrange for periodic blood tests to monitor for hematologic and thyroid functions. The reason for hematologic function, like with checking a CBC, listed as one of your major adverse effects is agranulocytosis. And if it is going to happen, it usually does so within the first 3 months of treatment, and it usually resolves within a few days when the treatment is discontinued. Also, hepatotoxicity, aplastic anemia, and vasculitis. And so because of that, agranulocytosis and the aplastic anemia, we will want to monitor those hematologic functions. We also want to monitor the patient's bone marrow function to make sure that as far as their bone marrow is concerned, we do need to do baseline values of the CBC, the kidney function, liver function, and all of those things, and of course the thyroid levels, the TSH, the free T4, the T3, to make sure that so that we know where our baseline is and what we're working from. Patient and family education, we want to explain the purpose of therapy. If the drug is taken in divided doses, we want to teach them to take those drugs every 8 hours around the clock. We may have to help them work around their work schedule, their children's schedule, that kind of thing. So we need to make sure to help them as far as that's concerned. Ongoing assessment evaluation, we want to monitor serum thyroid hormone levels periodically to evaluate the effectiveness of MMI and to assess the need for replacement thyroid hormone because the thyroid gland is suppressed. And so this is the end of endocrine.